Let's admit the doctor. And again, I would like, if will the studying or the teaching to be interactive. So after discussion with Dr. Satwat, I would love, that other doctors to be engaged as well. Okay. So, and if someone can volunteer to admit the doctors, just that will be helpful, because during the case, I will not be able to concentrate with Dr. Satwat and the admission. So if anyone can volunteer before we begin.
Yes, I can.
Yeah, okay. Thank you very much. Thank you very much. So, okay, Satwat, this is your case, and these are the 3 minutes timer. It is around, I think, 1.5. Yeah, is you can see Dr. Satwat?
I can, yeah.
Yeah, so you don't want me to enlarge the, okay. So just when you reach down, you want me to scroll up or scroll down, just let me know. Okay, and I will open the recording. I will the recording already open, so I will open the timer. Okay, the timer is yours now.
Can you scroll up, please?
Yeah, sure.
Can we scroll up, please? That's
Yeah,
all.
yeah, I think that's all. Yeah, that's all. Thank you.
Can we scroll down, please?
Okay.
Can we go down the last page, please?
Yeah.
Good morning.
Okay, we are not good morning. Okay, you might be
Oh,
good
sorry.
evening in
Good.
the exam. Yeah. Okay.
Yeah.
So yeah. Okay.
Good
So
evening.
yeah.
Good
Go
eve
go
Good
ahead, please.
evening.
Good evening.
I'm Dr. Satwat Mois from the surgery. I'm a GP trainee. Am I speaking to Jessica Brown?
Oh yeah, doctor. I'm Jessica.
Is it all right to call you Jessica then?
Yeah, yeah, sure, doctor. Without that.
So, Jessica, I mean, I hear that you are here to discuss your urine culture, which was just recently done.
Oh, I think so, doctor. Yeah, I bring the urine sample few days. I think yeah, a few days ago, and then because I had this stingy urine, and then I need to go to to the bathroom frequently. Um, yeah, and I think the urine dip was not significant. This way told me, but then I think the on-call GP told since I have symptoms, so we'll start the antibiotic,
Yeah,
and they will arrange another appointment with me today to discuss should I continue the antibiotic or have another antibiotic.
yeah, yeah, yeah. So, I mean, what is it that you want to complain about, Jessica?
No, I'm not complaining. I mean, you mean my symptoms? Well, there's still I have, I'm going, more frequent for wee. I sometimes even I cannot hold myself. I'm rushing to toilet. I cut short twice, and I'm not going out now. I'm worried that maybe I will wet myself. So I'm
Okay,
not sure what should I do, doctor. And was there any infection in the culture, doctor?
we'll definitely talk about that, Jessica. Would it be all right if I ask a few questions to put things into context, please?
Oh yeah, sure, doctor.
So, since how many days have you been having these symptoms?
Around 5 days now, doctor.
Okay, and you say that the 3 days course of antibiotics given to you did not touch it. So, yeah, is
Yeah,
that right?
nothing. Yeah, I didn't have any improvement at all. Yeah.
And have you ever had these infections in the past? Not that I have any record of it on the system.
To be honest, doctor, is not infection, but I have been suffering from my water work for a good year now.
Okay, okay.
So usually when I'm coughing, sneezing, or or even going to the gym, I feel when I strain, I'm passing some, I can't hold myself, to be honest.
I can't hear you correctly. You
I,
can't
I
what?
can't hold myself. I'm leaking. So for
Okay,
like
okay,
around the year, I will leak little bits. Okay, so I'm always wearing, pads,
okay,
just to keep my underwear clean.
okay. Yeah. And this has been ongoing since the past 1 year. I'm sorry if I'm repeating myself.
Yeah, yes, doctor, since 1 year.
Okay. So I mean, if we try to clarify these symptoms, how many times would you need to wake up at night to go to the loo?
For the last week, all the night I'm spending it on the on the loo, doctor. Every hour,
Hmm.
which make me shattered. I can't, in the morning I'm completely knackered, doctor. So
Yeah, of course. It's totally understandable. And what and um I mean, when you need to go, can you hold on to the urine until you reach the toilet?
no, doctor. As I told you, sometimes I'm cut short, and
Mm-hmm.
yeah.
Okay. And I mean, whilst you wipe yourself, have you ever felt that there's something hanging from down below?
No,
Okay. Um, so, and should we ask a bit about your periods, if that's all right?
yeah, sure, doctor.
Yeah. Can you tell me? And are you having regular cycles?
Oh yeah, doctor.
Yeah. And I mean, how would you describe your flow?
You mean my cycle?
Yeah. Do you have heavy bleeding or moderate bleed?
No, it's fine, doctor. I didn't see any change in my period. Really, I don't have, my period is normal. Will stay 3, 4 days, and there's no clots, and it's not painful.
So that's remarkable. Okay, and may I ask a few sensitive questions, Jessica, if that's all right?
Sure.
Yeah. Are you sexually active currently?
Oh, yeah, doctor. I have a boyfriend.
Okay. And I mean, do you use any contraception at all?
No, to be honest, doctor, we are planning to have a baby, so I'm not using any contraception.
Okay, okay. And I mean, if I see my record, you're only on the blue inhaler, isn't it?
Oh, yeah, for my husband, but I'm not using it anymore, doctor.
Okay. So that's very nice if you're planning to have a child together. So and have you noticed any discharge or a discharge down below?
No, doctor, I don't. I got what you mean. I don't think I have infection, doctor, from my, in my vagina. Yeah,
That's a reassure.
I'm with my boyfriend now for more than 2, 3 years, so I quite confident in him, and I'm not, I don't have any other partners.
Okay. And have you noticed any bleeding after sex at all?
No,
Any bleeding between your periods?
no.
Okay. So any significant family history of cancers or womb issues at all?
To be honest, doctor, I don't know. I'm a foster, so I don't know my family, to be honest.
Okay. So what thoughts go through your mind, Jessica, as to why this leaking and the water infections?
To be honest, doctor, I'm not sure what's happening. I thought it might be an infection.
Okay.
Um, that's only, but why I'm leaking when I'm coughing and sneezing? I know maybe I'm a little bit overweight, and they told me because of my weight that can happen. And I know I'm not that, I'm not doing a lot of exercises. Then they told me also maybe I need to increase my muscle, but I didn't get which muscle exactly, strength.
Okay, sure. And and what concerns do you have about this condition?
Doctor, I'm just because I'm planning to have babies, so I want to always to be tidy and clean from down, so we can have intercourse. But that's not happening nowadays. So
So
we are not intimate because of I don't feel I'm clean, and I feel shame to you got what I
oh,
mean, doctor.
of course. So
Okay.
would you want me to explain as to what might be going on, Jessica?
Oh yeah, please.
Yeah. So from what you are saying, that you leak urine on coughing and sneezing, and there's an urge to go to the toilet. I think you have a condition in which in medical terms we know as urinary incontinence. Yeah. Have you ever
Okay.
heard about this before?
Um. Well, yeah, I heard, but I'm not sure why I have it.
So I'll explain it to you. Yeah. So urinary incontinence is when you leak urine. Sometimes when you sneeze or cough, like you are having, and in that case we call it stress incontinence. And at terms, at times it's urge when you need to go and you can't hold on to your urine. That's called urge. A third type also exists when the two stress and urge incontinence happen together. Yeah. So
Okay.
there's lots we can do to help. To start off with, it'll be very nice if I can see you in clinic. Whilst you are here, I can examine you in presence of a chaperone. What do you say about that?
Yeah, sure, doctor. I don't
So,
mind.
yeah, and whilst you are here, I'll be able to examine you from down below, take a few swabs if necessary,
Mm-hmm.
and then I can thereafter refer you to the bowel and bladder clinic, um, um, which for pelvic floor supervised exercises, which are put into place for stress incontinence. Are you happy to for me to do that?
Well, if they will help, I'm happy, but I'm
Yeah.
not getting, so I'm not having infection, doctor.
Your urine culture and your urine test that was done in the surgery showed no infection at all. Yeah. However, we need to find out whether you have other conditions like diabetes. So, whilst you are here, my friendly nurse will do a series of blood tests, if you agree, which will include diabetes, your kidney and liver tests, if you agree. What do you say?
Yeah, sure. That's very helpful, doctor. I
Yeah.
really feel that you do care about me. Thank you.
And then when you once you're here, we'll talk about weight losing strategies, like exercises, or we'll talk about healthy diet. And if I mean, we can also experiment then for a couple of days, and if that's not working, we can always refer you to weight reducing services. What do you think about that?
Yeah, well, I will be more than happy.
Yeah, and whilst you are here, we will also talk about your alcohol and coke and drug addiction, if that's all right.
Oh yeah, I would like to talk about that. So you finish the case. Anything you will say is not accounted, but the last thing is important. You want to continue.
Yeah. So,
Okay.
in short, Jessica, I mean, I would really want to examine you today, examine you in clinic today. We'll have a series of blood tests done, and I mean, we'll have a chat together about how your weight is contributing to this condition of urinary incontinence, and I mean, how pelvic floor exercises and bladder training will help us with managing the urinary incontinence.
Okay. So
Are you
that's
yeah?
fine. Yeah, yeah, that's completely fine. Thank you very much. Take your breath and what you think, you give me a reflection. What you think you did fine, what you think you might change in the future.
So Dr. Slim, I am data gathering was my time management was not good.
Yeah, but
uh,
that will come, that will come with practice. It's normal that anyone, will have, problem with the time management, and the time management will come with time. Okay, first you are building the structure, and that's for the people who are still starting, preparation. That's completely normal. You are building the structure, and then after you have proper structure, you will try to compress it. That's normal evolution of, how your art of consulting happening. That's fine. That's completely fine. You will never be perfect from the first time, and you will never be perfect because you are keep learning and keep changing your practice. Okay, other than the time management, because as you said, you started your management at 3 minutes. That's very critical. Okay, we needed to start it at 6 minute maximum, 6 minute
yeah,
maximum.
yeah,
So you are
yeah,
behind the 3 minutes. Okay,
yeah.
and we can. Well, I do appreciate the case is not easy. The case have wide, wide differential. You ask most of them, but also not all of them. However, we will discuss how we might, compress your questioning. What else?
So I tried to keep to the structure,
Mhm.
and I tried to incorporate most of the information given in the scenario. which was her alcohol and cocaine addiction. I did not ask her job. I asked about her home situation.
Okay. Yeah, we didn't
And
ask. Yeah, it's, the psychosocial will not completely, I mean, dig in, and you need to know, psychosocial is always an important, hole that people are, filling in. So take care about psychosocial. And in this case, I think there will be a lot in the psychosocial. Because if you look at it, is this an ordinary case of incontinence? I don't think so. Age-wise, she is 27 years old. Is it
hmm,
common 27 years old to come with an incontinence? Could be yes, could be no. Especially if she have multiparity. Some ladies are starting to have babies then when they are 19 or 18. But is she? I didn't hear you asking anything about the obstetric history, which is very important in case of incontinence. But she's 27. Is it normal? Yeah, if it is 50, 60s, well, I expect that they will get incontinence. But 27, I will think I need to think outside of the box a little bit. Um,
so she's obesity too. And if
yeah,
she's
yeah,
that heavy, and she's
mhm.
I mean she's under the effect of alcohol and drugs.
Yes, but
Uh,
that's why I'm telling you, I didn't explore this, and I try when you start at the end, and I said, oh, the we need to discuss the cooking and alcohol a little bit. Then I give you more time, but you didn't continue on it. So the trick was in this bit, and we'll discuss that. So, so what do you think might be the trick if it's in alcohol and cocaine? Yeah, is that what?
I'm thinking, Dr.
Yeah.
Seen.
Well, alcohol can make what? Can make neuropathy, yes. Well, neuropathy can make bladder problems. That you might ask her, but if you ask her, she will tell you, I stopped the alcohol drinking totally, and because I'm planning for babies. So that cooking can make a problem.
Okay.
Yeah.
Yeah.
So what else? Why you become sad? Well, the case is not easy. It's a difficult case. What cocaine? What else would make a difference?
Her, her being overweight
Yeah,
and
which you address it. You address it nicely. You said overweight, and she know. So you don't need to explain more and more because she already know. Yeah, but if a case come, for example, doctors and the patient having, a BMI is high, her weight is in the higher side of the scale, can anyone explain how you will, or you, Satwat, can you explain how you will explain to the patient how might the extra weight affect her bladder? Anyone can explain how extra weight would affect the bladder function to the patient in simple terms?
I think I would say that extra weight can cause pressure on the bladder, and that's what make you
Yeah,
keen to have some more
mm,
leakage
yeah, yeah,
than
yeah,
other individuals.
yeah. Carrying extra weight around your waist will put a pressure on your bladder, and that will make you leak urine. Well, this is what is happening. Well, increase in intra-abdominal pressure will make the patient leak. And that's what's happening with, if you're carrying extra weight. Plus, for sure, the strain on the muscle and the stress on the muscles will make the muscle become weak by time and fibrosed. Okay, what else, Dr. Satwat?
then in I did the eyes. I asked you.
Not all, Dr. Satwat. You did the I, I did the C, but you didn't do the E, the expectation. So you was managing the case without knowing the patient expectation, and that's critical. You know, yeah. So we didn't know what she was expecting from us. was she expecting antibiotic or what she was expecting? However, the patient was lovely. The patient was approving, and she felt that you are caring because you do really care about your patient. And the way you are consulting, it seems to be that you are do care about the patient. You are trying to help her as much as you can. But don't forget, expectation is important. Because that is the first thing that you need to address in the ice. The beginning of it. So she want to know why that's happening to her, and what she's expecting is to give an answer for what is happening, which might not be you might not be able to give it at instantly, but you need to explain. Well, there is a lot of causes can make you having this mix incontinence. One of them is A, B, C. I think in your case is C. However, we might consider referring you to the bladder and the bowel, or the urodynamic team, and then they might give us the answers. But before doing that, I need to do ABC, which you did. You did, said I need to bring you face to face, and we will discuss that in details. Don't worry what's going on. But I need first to hear from you, and because this is the only way that you will be able to learn, and the other doctors will be able to learn by seeing, the mistakes of other and learning from them. So what you think you may do differently?
Differently, Dr. Salim, like you said, shrink the history a bit.
Yeah,
At
so I will tell you from the beginning because I waste your time around 1 minute. Okay, so we said in the beginning, try to use pre-existing information, and when you are using pre-existing information, make a good summary of what is there and let her know. So you tell her you came for water symptoms. No, tell her I can see you had an antibiotic and this and that and that. How's been going now? This means how is your symptoms? And then she will start to tell you if her symptom improve or not improve, and then you say, okay, so tell me more about your symptoms. Again, that was crucial. That will save you at least 30 to 60 seconds, which is around a minute. So and then you will be able to, at least by doing that, at least you will start your management at 4 minutes. Okay. This is one. Okay. And then in your questioning, yeah, that's it was nice. Yeah, for sure. You need to ask about prolapse, you need to ask about period, you need to ask about sexual history, but then also you need to ask about other things. Yes. You need to ask about back problems, because if the problem, if she have disc prolapse and she's, overweight or something, then she might come with bladder symptoms, isn't it? And what else you need to ask? You need to ask about bowel. Yeah, so how is her bowel? She's opening her bowel normally, or she have constipation, and chronic constipation is making her pelvic floor dysfunction and making her having these symptoms, or what exactly? So that was important as well. So does she have, distension, or although she's 27, but ovarian cancer is less likely in that age, but who knows, she might have something. So ask her about, distinction, early satiety, all of these differentials should be, asked, in a faster way. Okay, so I know that you might not, they are not, attended in your, in your mind at that time because of the stress. For sure, the situation is not an easy to perform, and someone to watch you. So next time it will be easier for you. Yes. So
of
bladder symptoms, vaginal symptoms, okay, including STIs, cancer, cervical problem. Does she do her cervical smear? Okay, so anatomically, so you can think about the things around the bladder anatomically, and that will be easy. Yeah, ovaries, and then bowel, and then neurogenic bladder, which is, from the back. Does she have, disc prolapse, lower back pain? Does she have any numbness or tingling in her legs or weakness? Yeah.
yeah,
Okay, so that's in the questioning, and please don't forget obstetric history. Okay,
yeah.
it's not acceptable, if the patient coming with incontinence, that you will need to know her obstetric history. Surprisingly, this lady, she tell I've never been pregnant, so she doesn't have, any strain from before on her pelvic floor muscles. So that should let you think, a little bit outside of the box, little bit. Yeah. And then we said about the eyes, and then it's important to ask about alcohol here, okay, and symptoms of vitamin B12 deficiency, okay. You don't know if you have neuropathic pain and demyelination syndrome or MS. All of that can come with your neurogenic problem, can come with bladder symptoms, okay. So especially in that age group, it's different than the patient who have multiparity and coming in the older age group. So always think the age group is very determinant of the cause, because this patient can be MS. So again, asking about about neurological symptoms is important. Okay.
Yeah.
And then you will, and she already tick a lot of boxes. She told you she I don't have, sexual infection. She told you I don't, I don't think that I have, any issue in my period. She was, because the differential is a lot. So the patient was trying to help by ticking the boxes, but also she give you a cue that you also giving you a hint. Okay, well, salbutamol, asthma. Well, I'm not using the inhalers anymore now. So why she's not using the inhalers? Why, it's related, okay? It's related to the case, and we'll explain that at the end of the discussion. And then I think the rest you did it fine. I mean, the management was fine. You said you did say the diagnosis, differential diagnosis. You did explain to her. Okay, very good. Okay. And you did bring her in, and always don't forget when you say to the actor that you will bring, or the patient, I want to bring you in, you need to tell why. And then you said, yeah, I need to to feel your tummy to see if there's lumps or bumps. We might need to to check your to examine your vagina, see how is your pelvic floor muscle tone. Okay. I might need to do, speculum examination and have a look at your, cervix and feel your womb if there's any enlargement or lumps or bumps there. Okay. Um, and then swabs, it will not be routine, because if the patient doesn't have symptoms of, STIs or something, you don't think you will need to do any swabs at that situation. And then bloods, you did also cover some of the differential. You said diabetes, that was good. Kidney, liver. You could say, okay, also vitamin B12, folic acid. I need to make sure that inflammatory marker to exclude, MS or inflammation at your nerves. That would help you in also covering the differential. You could save it here. So if you couldn't find time, and this is a trick, this is a good trick to learn. If you couldn't find the time to do all your differential and in the management bit, and you from your questioning was able to reach a proper diagnosis of differential diagnosis, then you don't need to continue your questioning. You might stop it, okay, and the sake of time, and try to, when you reach the management, tell what you will do based on your differential and say some of your left differentials, and that's how you might be able to gather more marks. Is that clear, doctors? Yeah, this is a way that you can save your time with. So if you are not able to do all the questioning in your differential in the closed questioning bit, then you in the management you would be able to try to say the rest of your differential through your management plan, and hence you will be able to gather you will be able to gather some marks in in the management and in the data gathering as well. Okay. And then you did the referral, but I think the referral would be at this point, early, isn't it? Because you still don't have enough differential. Okay, you might say that we would consider referring you to the bladder and the bowel clinic, which they can give you a lot of help and a lot of support. And coming to the to your concern that you are having a problem with the you're incontinent and you cannot go outside, outside of your house, because that's important. You need to solve this issue. Otherwise, her mental health will be affected. So what you will tell her, what you will, is your suggestion about, the incontinence, how she can live with the incontinence, and the end term that you will reach the diagnosis.
So we can tell her that. Um, hello.
Yeah, I'm with you.
Yeah, we can tell her that I mean whilst you're having the incontinence, we can use I mean you can continue to use the pads because it's not an overnight fix. It'll take time.
Yes, yes, you are right.
Yeah.
Then during that, you need to give her some, some instruction, some, way to, to fix her life.
So
Otherwise, she will become fed up in the middle of the way and she will not continue because, bladder exercises would need 12 weeks, 3 months, pelvic floor exercises would need another 12 months, 12 weeks. So at least to start to give an effect, if you will start any anticholinergic or beta agonist, then that will need at least 4 weeks or 6 weeks to see the effect of it and if it will work or will not work. So there is a lot of, that will take time, okay? And so meanwhile, how you will help her?
so I mean we can give her patient information leaflet from Urology UK. We can I can give her signpost her to the Bowel and Bladder Foundation, where she can have these pads and other accessories
Yeah,
for free.
exactly. Yeah, exactly. So you have an incontinence team, okay? You have, she can buy, incontinence bed sheet. That's important. She can wear incontinence pads. She can wear incontinence underwear, and I will show you a picture in a minute, okay? That's important. And what you should have asked also in your data gathering in her lifestyle. You need,
About
yeah,
alcohol,
yeah.
fizzy drinks, caffeine.
Yeah, exactly. So bladder irritant, that's important because this is how you will give the lifestyle modification. So the bladder irritant, the water intake, that she's taking enough water intake because concentrated urine can irritate her bladder, isn't it?
Yeah.
Yep. Um, and then you address the weight, and I find that very helpful. And then you said but then don't forget also red flags and follow up is important. Okay. So what would be your red flags?
Red flags here would be
Infection, yeah. If you have a fever, okay, we need to know if you find the blood in your wee. We need to know if you have any leg weakness or numbness. We need to know. Okay, so yeah,
yeah.
so okay. So did anyone have what might be the case until now? Has anyone might give thoughts about it? And it's related to cooking. So
Yes,
anyone who said yes?
yes, Rohan.
Yeah,
Sir,
Rohan. Yeah.
this is related. There are two things. One is obviously harmful alcohol drinking because alcohol drinking will, one is neuropathy, irritating the bladder, and cocaine addiction can also cause similar symptoms. And I will also be interested in exploring whether she has other addictions because one of the other common addiction is a
Mhm.
ketamine drug use. If
Excellent.
somebody who uses
Okay.
ketamine will have
Mhm.
a very similar symptom. So
Excellent.
I will just
Excellent.
explore if she's using anything
Yes.
else.
Excellent. Excellent. Yes. So that's right. So if you ask this patient, she told, no, I'm not drinking alcohol anymore. Okay. And cocaine, she will tell you, oh, thankfully, my colleague was make me to stop the cocaine and using another cheaper version. Okay, so ketamine is now very common street drug. Okay, and you will find a lot of patients in your practice, I'm sure, but just try to ask about it. Okay, that they are having, ketamine instead of cocaine, and because it's cheaper, and wrongly the people believe that is the ketamine is non-harmful because it's medical drug, isn't it? So ketamine is very common to be used in the medical field. We are using it, in the emergency and day-to-day, everyday practice, and the anesthesia, they are using it every day and every day because it's good sedative, especially people with asthma. And that's why she told you, I'm not using my inhaler anymore. She's using the ketamine, she's sniffing the ketamine, and that is helping her asthma. So there was some hints there. Okay, it's a difficult case. It's not an easy one. Okay, but But then you need then to advise also regarding, the alcohol, the CGL. Okay, you need to advise that no, actually, I think you might have, yes, you have urgent mixed incontinence, but from what you told me, I can't find a specific cause of it. You might have that by, you might have what is called ketamine bladder. Okay, ketamine bladder syndrome is becoming more and more popular, and you need always to have it in your differential when the patient, either male patient presenting with urinary symptom that you cannot, address it, you don't know what is the cause of it, or a very young female that have history of alcohol, of addiction, and then suddenly she started to have, bladder problems. Okay. Unfortunately, ketamine, okay, we'll see some pictures. Ketamine is coming as a liquid form, and then they are cooking it. So cooking it means that they will put it under heat, and that will make it crystals like cocaine. And then they can sniff it, they can inject it, they can take in all form, they can digest it. So all form of abuse can be done by ketamine. And most of the drug dealers now are just, mixing it with the cocaine. So just, to me, just, a bad quality cocaine. So they will put the cocaine with the crystals of the ketamine and sell it as pure cocaine. And the patient will come with these symptoms and they don't know even that they are using, not original cocaine. Okay. So coming back to the incontinence, and we will discuss the bladder, the ketamine bladder. Okay. So do you want to add anything, Dr. Satwat?
No, doctor.
Yeah. Yeah, it's difficult. I told you it's not an easy, but it was, it's a good. Okay. And as I told you, I met this case for my first time um, a few weeks ago, and it was a good learning point for me, to be honest. Okay, so, and the problem with the ketogenic or ketamine bladder, if it's reached the irreversible stage, the bladder gone. Okay, there is no way to fix the bladder. Okay, that's why these patients need to do two things. First, the gynae urology team will not make any operation for them, okay, except if they are clean. So first thing, you need to refer the patient to the CGL, okay, and then meanwhile you are trying to control the symptoms for sure by different drugs, which will go through that, okay, and then after that you need, the patient to be proved from CGL that he is clean or she is clean, and then after that they would proceed for, bladder reconstruction, because the problem with the ketamine that it's the when the kidney is excreting it from the body, it will excrete it as a crystals, and these crystals are precipitated all over the urinary tract symptoms and cause the bladder to be contracted, okay, and fibrosed. Then the bladder, finished. The bladder is just a fibrosed organ, okay, and then the only way to fix that is just by removing the bladder and making a conduit either from the intestine or even making urinary diversion. So it's very, very bad, very bad side effects that ketamine can cause. However, in general, if a case of incontinence presents and for you and your surgery, I like to think in three levels again, the rule of three. Is it urge, stress, or mix? And then is there is any cause? And the causes I divided to three. Is it something intrinsic in the bladder itself or the urinary tract, or extrinsic, like compressing symptoms from the surrounding organ, or metacentric, if there is any metabolic cause, like you said, diabetes, hypercalcemia can cause that. So it's always better, always good to think in that way. And again, the differential will be massive. You might not find time to ask all the question, but at least ask the anatomical question in your differential, okay? And then when you do the management, nominate the other differential in the blood, blood investigation and in the examination. So like that, you will give the widest, the widest enumeration of differential in your exam, and you will be able to, to gain more marks. And this is how I am thinking, how to do the case in the real life. Okay. So as you said, what does it mean incontinence? So incontinent mean involuntary, involuntary leakage of urine. Okay, either due to intrinsic cause of the urinary bladders or the genitourinary system or your other illnesses, and then that will lead us to three types of incontinence: either stress incontinence, which sphincteric failure, okay, when there is increase in the intra-abdominal pressure, and the patient will answer to the question, do you leak when you cough or sneeze or even doing exercise? But urge incontinence mean that involuntary leakage of urine due to hyper or irritable bladder. Okay, the bladder is irritable. They cannot. The bladder cannot hold enough urine in it without contraction, which usually irritation of the detrusor muscle. Um, and then the patient will answer the question of do you feel do you leak when you urge to go to pass urine or not? Do you have time, or do you cut short? I'm asking like that. Do you cut short when you need to rush to the toilet? Okay, and then if the patient say yes, then this is urge incontinence. Urinary urgency. So overactive bladder need three symptoms, not only the urge incontinence. So need three symptoms, which is urgency, frequency, and nocturia. Okay, which you ask. How about the when the nighttime symptoms? And then yeah, she told you, yeah, I have nighttime symptoms, and she's going more frequent, so she have overactive bladder. And then the mixed incontinence, which we deal with it according to which more predominant symptoms. Okay, risk factor. These are the risk factor of what is called pelvic floor dysfunction. So my question is, do pelvic floor dysfunction happen to female per se, or can happen to the male? And if it's happened to the male, how the male will present? Because you will find it also in your real life. Does anyone know how the pelvic dysfunction, if it's present in male, will present? What the patient will come complaining
So,
of?
same, Dr. Salim, frequency, urgency, hesitancy, or
Yeah.
storage symptoms, dribbling, hesitancy,
Yeah.
and
Yeah, you are
uh,
right, but also some important thing that will come to the male per se. What do you think?
Erectile dysfunction or
Erectile
ejaculation.
dysfunction. Yeah, or ejaculate. Yeah, for sure. And that's why unfortunately all of us will empathize the importance of Kegel exercises or pelvic floor muscles exercises to the female, but actually it's important to the male as female. And if you ask, you will find that the erectile dysfunction is very common in young age nowadays, okay? Because most of the people are either sitting all the day or either standing all the day, making, playing in their phones, and that will put more pressure and pressure on their pelvic floor. And then there is no exercises, and even if there is exercises, most of the people will not concentrate in their pelvic floor. They will concentrate in heavy weight lifting or gym or and then in the gym you are increasing the core muscle, and then the core muscle will put more pressure on your abdomen, in the abdomen, more intra-abdominal muscle, more intra-abdominal pressure increase, more pressure on your pelvic floor, more problem with the erection. So if you have a patient coming with erection problem, tell him to do pelvic floor muscle exercises. That will help. Okay. And the other thing also, something called deep pelvic syndrome, okay, deep pelvic pain syndrome, okay, or irritable pelvic pain syndrome, that's also common. You will find a lot of patients coming with, pains, and they will say, okay, and most probably we will mistake it by hip arthritis, hip osteoarthritis, sacroiliitis or sacroiliac joint dysfunction, but actually the problem in the pelvic floor muscles. And when you start to ask the patient to do pelvic floor muscle, he will come after 3 months, saying you, I'm fine. I'm completely fine. The problem is in my pelvic floor. So it's very important to address that, to have the knowledge that the pelvic floor muscle are very important, very, very important. Okay. The risk factor, anything can increase your, it can increase your intra-abdominal pressure, like constipation or cough, and then the usual, risk factor of a female hysterectomy, obesity, or menopause. And the other question that we will answer in few minutes, why menopause would, To be honest, it's not female menopause because also males can have menopause, okay, which something unfortunately also a lot of us are dismissing it. So, and the menopause of the male is decreasing the testosterone, okay, and the menopause of female is decreasing her estrogen. So, can anyone say, give me a hint, why would the menopause cause irritable bladder for the female?
So
the
menopause, sorry.
Yeah,
Yeah.
anyone, maybe we'll start with Satwat and then we'll go to Ruhan because Ruhan will answer because it's his specialty. Okay, go Satwat.
Atrophic vaginitis.
Yeah, atrophic vaginitis is part of it, but then atrophic vaginitis will give you so why atrophic vaginitis will cause your bladder to be irritated.
I think it will change the vaginal flora. What do you
Okay,
say?
and then
Don't know.
okay, so what about Satwat? Yeah.
So I think, Dr. Slim, with menopause come lack of estrogen and progesterone that maintain the normal health of the vaginal system as a whole. So when there are no
Okay.
hormones there, the muscles go lax,
Okay.
and I mean they're not held in their original position. This is what we see in our elderly population.
Okay, yeah, Madhu, but then that will give you more stress incontinence, isn't it? Because if the lacks of the muscles there, so that will give you more stress incontinence. But why she will have urgent continence? I'm completely with
Because
you. Well, estrogen when it decreased, so the muscle strength, the
the,
connective tissue health, the
the
atrophic, so
bladder
it's cool. Yeah.
the bladder will retain the urine,
Mhm,
and it'll continuously irritate the bladder.
mhm,
So
mhm.
that's why in these people, post maturation ultrasound is done to see whether there is post residual urine.
So that's a different story because post residual urine means that the trousal muscle contraction is bad. So that's the opposite. So that's not incontinence. Then this relaxant, this dysfunction in the trousal muscle contraction, which can happen with old age, can happen with menopause, but there is another thing, okay, but you are mixing the things here, okay. So post residual this residual urine mean that the trousal muscle is not contracting properly, so that means that they should accommodate more or less more urine, uh, unless she have mix, okay, so she can have the trousal muscle dysfunction as well as part of it hyperactive as well. So, Rohan, would you
I
give
think,
us a spotlight in it?
yeah, I mean, it's something to do with collagen tissue. So estrogen and maintaining a collagen tissue. So for anything that stretches, the collagen, if you go at a microscopic level, collagen plays an important role. After menopause, because there is no estrogen, obviously there is problem with this collagen tissues. That is why whether the thinning of tissues, so estrogen and collagen tissue. So it's something to do with collagen at the macro
Yeah,
level.
yeah, I'm with you all, but also there is an important things. Okay, so atrophic vaginitis is a reflection that the estrogen is low. Okay, and then most of the studies find that when the estrogen is low, there is the gag layer of the bladder. So they find that the mucosa of the bladder is covered either in the male, either in the female. Okay, covered by glycoproteoglycan, so polysaccharides and protein.
Glycosaminoglycans.
Yeah, exactly, the gag. So this layer is acting as a protective layer from the contacts between the urine and the mucosa. And the estrogen, when it's decreased, and the testosterone in male, when it's decreased, okay, this layer will become defective, and then there will be direct contact between the mucosa of the blood. And I will show you some diagram. So the direct contact between the urine and the mucosa will make the bladder irritated, and then that will make, hyperactive bladder or urge incontinence. Okay, it's good to understand the pathophysiology, so you will understand how we are, dealing with the patient, how we are treating it. Okay, and even that will make your questioning with the patient more reasonable. Okay, so if the diagnosis depend on, as we said, on the history. You need to bring the patient to examine him, because if you have palpable bladder, that's maybe a cancer, then you might need to refer her, or if you have a prolapse. Okay, and then yeah, this is something unfortunately not common in the GP land, that you need to assess the pelvic floor tone. But during my training, when I went to the gynae rotation, I went multiple times to the gynecology clinic, and the nurses teach me how to do that. It's very important. It's an easy and simple. Just to ask the female to squeeze under your fingers, and you will be able to assess the tones of the pelvic floor muscles. Okay, urine depth, well, you need to check hematuria, because again, microscopic hematuria from ladies above 60s, and then having dysuria or high white blood cells as an indication, and for the referral, and then under the 2 weeks wait. And then don't forget if the patient have overactive bladder, to do bladder diary. Okay, and I will show you some example of the bladder diary, how to read the bladder diary. So if the patient, normally the patient, will be the normal patient will be able to hold, or around 400 mil every 4 hours. Okay, but an overactive bladder, it will be very less. Okay, so when he will go maybe every hour, every 2 hours, and then even the amount of urine that's coming out is a small amount of urine. And then urodynamic study is not our call. It's usually the call of the secondary care, because they depend on it, on when they will do the surgery and what surgery will be appropriate for the patient. Okay. But in general, stress incontinence, if it was not operated from before, it doesn't need urodynamic study. But however, if you reach to that level that you need, to do urodynamic study, let the referrer, that your consultant do that for you. Okay. Referral, when to refer a lady coming with incontinence. So if it's more than 45 years old, and then she have unexplained visible hematuria without UTI, or recurrent hematuria after treatment of the UTI, that's an indication for refer under the cancer pathway, the 2 weeks wait pathway, and also the other age cut. So these are important. The age cut: 45 visible hematuria, 60 non-visible hematuria, and either dysuria or raised white blood cells in the full blood count. Non-urgent referral will be, more than 60 with persistent and recurrent UTI symptoms. Also, don't forget that it's not uncommon if the patient have, more than 60, she might have microscopic hematuria just without symptoms, just because she have atrophic vaginitis. Then it would worth, in that cases, before rushing to refer to the gynae team, is to try estrogen, vaginal estrogen, and then reassess the hematuria and see how it is. And then non-urgent referral will be if there is any anatomical abnormality. So if a palpable bladder, or urethral, or persistent pain in the other, which pelvic pain syndrome, or chronic or pelvic mass, or if there is any fecal incontinence, and usually that will be after delivery. The patient will have a fistula or something because of the forceps, or traumatizing delivery. Then that will need to be referred for the gynae. That's a summary. What are the advices, and what needed to be done in general for both urge incontinence or stress incontinence? You will need to do pelvic floor exercise, okay, and lifestyle. So the first two things are common for both lifestyle and pelvic floor muscle. And lifestyle will include, decrease the bladder irritant, increase the water intake, okay, especially around 1.5 liters per day, and keep doing the pelvic floor exercises, and eating healthy and losing weight. Okay, keeping the BMI low, and then eating healthy. Bladder training, would be anyone able to explain for us, or how we will explain to the patient bladder training?
So what we need to do in bladder, tell the patient in bladder training is, suppose whenever they have the urge to pass urine, because bladder training is more important in cases of OAB, overactive bladder.
Yeah, yeah,
It's not
yeah.
much of it's
Stress
or it's a
yeah,
mixed incontinence, not in stress.
yes, yes.
Because the mechanism between OAB and stress incontinence is completely different. I'll explain what it is. So OAB, suppose if let's say they have an urge to pass, so you should ask them, try to postpone it. So initially they are likely to meet with an accident. You have to give positive affirmations. You have to have a good counseling that it can happen. Then with time, the bladder they will be able to hold more and more urine. So more and more time will go, and that's how the bladder will get trained. One most important thing is they should have patience, and they should be explained that there will be occasional accidents, but they have to keep going.
Yes, excellent. So to be timely framed, that's very good. Yeah, excellent. Would you like so pelvic floor muscle exercises? There is a lot of videos. Okay, you can
Mhm.
guide the patient for them to to watch it and to learn how to do it. Okay. The other thing also, we have a Squeezy app, and we'll have a look at it in a minute. What is the Squeezy app? And then the biofeedback, and these are devices, sometimes electronic, sometimes non-electronic. You can insert them in the vagina and help the patient to feel their pelvic floor muscles. And would you like to give an advice, Dr. Rehan, how you are explaining how to do pelvic floor, how to shut the back door
Yeah.
and the front door?
Yes, absolutely. So
Yeah,
the
sure.
thing is, I mean, this is with whatever my little experience,
No, no,
whatever
go
my
ahead. Yeah,
decade of experience in gynecology.
yeah,
Uh,
yeah.
so the thing with stress with pelvic floor exercises is it's called ease and squeeze. So most common mistake which is commonly done is that the woman will squeeze the abdominal muscles. So that's why examining them, so we ask them to contract. So you have to tell the patient that imagine you're traveling in a bus, you don't have access to a washroom, and you have to hold your urine. How will you urine? So you have to squeeze the muscles around the vagina, and you have to do them. When you do it at home, you should actually empty your bladder. Don't do it on a full bladder, because that'll be much more uncomfortable. You have to do a count of three. So 1, 2, 3, squeeze and ease. Squeeze and ease. Do a set of 8, 3 times a day, just to begin with. 8 to 10. So, and you have to explain to them that obviously it takes patience, it will take a few months. So this is called easing and squeezing. You can do that while you are at work. You can do that while you are cooking. You can do that when you are watching television and in the privacy of your home. So that is how you teach them. So you have to squeeze the muscles around the vagina, count of 3, and squeeze, and gradually increase it. But do a repetition of at least 8, 3 times a day. Do as much as they can. The more they do, more the merrier. That's how you explain to them. And the evidence has shown that the supervised pelvic floor training is far better than unsupervised.
Sure.
So if we have a physiotherapist who has special interest in pelvic health, so they can actually teach them, and you get this vaginal cones and biofeedbacks. So the evidence has shown that is far more effective than just doing it by yourself. So that's
Sure.
how you will tell, very simply.
Sure, sure, sure. And sometimes I will tell them, if you want to have a look at your urethra, where you are, holding the muscle, that, you can see the urethra actually elevated when you are holding the muscle. That also one of the things. And in the NHS, website, there is a lot of videos. Then we can also guide them to go through it. And, it's very helpful, but just give them the time frame, when the expectation. So it's like any muscle, need consistency, need to grow, and to increase the tone of the muscle, that need at least 3 months, to see the benefit of it. Okay. Then then the other option after the pelvic floor muscle exercises, the bladder training, and then would be in the urgent continence will be trying, to relax the trousal muscle, either using anticholinergic, okay, or using the beta-3 adrenoceptor agonist. And then in the female that have atrophic vaginitis, you can give her just estrogen, or sometimes they can have a trial of desmopressin. For the stress incontinence, you need to, to try to increase the strength of the sphincter of the bladder, and they find that the duloxetine can help, okay, but that will be resort for the people who doesn't like, or don't want surgical intervention, or don't fit the surgical intervention. And all the surgical intervention for the stress incontinence depend on increasing the muscle, the strength of the sphincter, either by, intramural bulking, and which is now taking the fame, and because it's an easy, and then I think it's only a day case surgery, it doesn't need admission. The other more difficult one is just, adding an extra sphincter through, or, operation in the muscles of the pelvic floor muscles around, or adding a sling, or mesh. For the urgent continence, is that the surgical intervention will be in the secondary care, either also paralyzing the detrusor muscle by using, botulinum toxin. It's selective paralysis. Not all the muscle fiber will be paralyzed. Okay, the consultant will inject, specific areas to, partially paralyze the detrusor muscle, or even you can do sacral nerve stimulation, and we'll see the device of the sacral nerve stimulation. It's like TENS therapy, so it's TENS machine but specialized to stimulate the sacral nerve, and we'll see the picture of it. And then lastly, you can do, either bladder diversion, or cystoplasty. Okay. Uh, Adjuvant, meanwhile, that's what you need also to show that you are aware about that. You are addressing the need of the patient, that meanwhile you need to use other things that can help the patient, either catheter, which I don't like me myself, because infection can be always invited, but you might use catheter, because catheters either indwelling or external catheter. For the male, you can have condom catheter, or conduit catheter for the female, and pads and incontinence devices, or or even commodes just beside the bed. These are the gag layer, okay, and then the gag layer acting as a protective mechanism, to prevent the contact, direct contact between the mucosa and the irritant in the bladder, as the potassium and the urea. And thankfully, this layer are able to regenerate itself if you give her the chance to. And then, one of the treatments is to give the artificially sensitized layer an injection therapy every month for 6 months or 12 months. Okay, so that's done in the secondary care. Okay, but it's easy. All what you need, they will put a catheter, okay, a plastic catheter, okay, self-inserted, yeah, sometimes, and then they will inject the substance, and then remove the catheter again, and they will ask the patient not to pee after the injection for around an hour, and that will help, the regeneration of the layer. Okay, what I need from this slide is that we need time. Okay, so we need time. So for the pelvic exercise, or the pelvic floor muscle, we need at least 12 weeks, and then for the medication, so 3 months, and then for the medication to say that we need to upgrade the medication, or failure of medication, either anticholinergic or beta-2 agonist, they need at least 4 weeks or 6 to 8 weeks, okay, to say that it's ineffective. Okay, so that's the diagram of the pelvic floor muscle, and how's the importance of the pelvic floor muscle, keeping your rectum, your urethra, your bladder in place. And you need, there is a big topic called pelvic floor muscle dysfunction syndrome, okay, which patient can present with erectile dysfunction, sexual dysfunction in the female, fecal incontinence. So always think patient coming with fecal incontinence, is the problem in the pelvic floor muscle, or what is going on? And then in the female, for sure, uterine prolapse, and problem in the bladder. Okay, some of the causes of urgency. Don't forget, urgency in males also can be signs of PBH or prostatitis. Okay, the anticholinergic, which anticholinergic, because that's important, especially in elderly population. So which anticholinergic you would usually prescribe to the patient, okay? Because you don't want to prescribe the anticholinergic and the patient will come with cognitive impairment and hallucination and the delirium after starting it, okay? Especially in elderly population. So NICE usually is advising using oxytocin, exobutine, I'd say, because the exobutine is the cheapest variant, and they're actually efficacy-wise, all of them are the same, but then side effect-wise, usually the darifenacine is the safest in elderly because is selective. This is one, and then also crossing the blood-brain barrier is not much, is very low, and that will make the side effect and anticholinergic burden less, and the cognitive impairment less and elderly. So if an elderly female present with urge incontinence, I will start darifenacines, okay? And but if a young female or young male, I will stick with the oxybutynin. Okay, this just always remember elderly population. Okay, you need, if you will add anticholinergic to them, you need to calculate the ABC score, the anticholinergic burden score, and if it's more than 3 or more, you need to do something about it because that increase the morbidity and mortality of the patient when the ABC score is 3 or more. Unfortunately, all the anticholinergic related to the bladder are 3 or more. So we can see here all of the exbutynin 3, even sulfenacine is 3. So it's little bit risky, little bit, not an easy decision. If you reach that, you need to give, a medication for the patient. The other choice would be the BPP, the beta agonist, which will make, the sphincter of the bladder, or the will make the detrusor muscle relax. Okay. And we have two choices, either mirabegron or vibegron. Well, mirabegron, the problem with the mirabegron, first, both of them are expensive. Okay. So both of them are costly on the NHS. The issue is that also the mirabegron, the side effect of the mirabegron is a lot. Okay, so you need to always check the blood pressure of the patient because it's an adrenergic stimulant. Okay, so it will increase the blood pressure, increase the heart rate. So if you decide to start the patient on it, you need to keep checking the blood pressure, and then the mirabegron also can cause problem with the liver and with the kidney. So with kidney impairment, if the eGFR is less than 25, so mirabegron is contraindicated, and then as well as the liver dysfunction. Okay, if the patient have liver issue, don't use mirabegron. Your choice will be the vibegron. The vibegron is less side effects, liver friendly, kidney friendly, and as well as will not increase the blood pressure as frequent as the mirabegron. And they don't need a frequent monitoring of the blood pressure. If you start patient on mirabegron, you need at least monthly to double check the patient heart rate and blood pressure. Okay. Well, these are some picture regarding that's the Botox injection, and then they will, Botox injection will be through cystoscope, so the will enter through the cystoscope and start to inject the bladder. And then these are the sacral stimulation, okay, or sacral nerve stimulation, okay. Electrodes, it's tense machine electrodes outside the body, and then that will stimulate the sacral nerve, and that will, stimulate the supply of the sacral nerve to the bladder, okay, and that should help the overactive bladder. Uh, Adjuvant therapy, so you have multiple over-the-counter, either continent sheath, okay, or for the bed. So, the patient will not need to change the bed sheath every now and then, or on continent underwear. There is male variant, female variant with different, designs. And then at the end, the daycare in catheter, which the patient can mobilize with it, just, he will wrap it around his thigh and go around whenever he wants. So the vaginal dumbbells or biofeedback is just, rubber tubes or rubber sling that the female can insert it in her vagina and then squeeze on it and hold, squeeze and hold. Uh, there is a manual one and there's electrical one where, they have a sensor and sense, and then they will be able to sense how much squeeze the female are providing, and that will make the pelvic floor muscle squeeze better. Okay, as Dr. Rohan say, sometimes or most of the time the females will contract their abdominal muscle thinking that they are contracting their pelvic floor, and so that device will help them to find their pelvic floor muscle. It's not an easy, to be honest, so they will need some time to be able to contract their pelvic floor. And the other thing, sometimes they are contracting their gluteus maximus or minimus, and then again, it's not the pelvic floor until they find it. That need time. Okay, that's why the guidance is saying supervised, pelvic floor muscle exercise. Some of the important websites. So these are example of bladder diary. Let's see. I hope it will be able to share. Let me close this example of bladder diary. Okay, and how to fill it, so you can see the good feedback on how to fill the bladder diary. Okay, and then it should be for 3 days. That's important to explain to the patient for 3 days. Okay, and then you will see it, and then you will need to use it even in the follow-up, because according to the bladder diary, you will see if the medication is giving effect or not. So I just need, yeah, so 3 days, okay? These are the bladder diary. So the type of fluid you drink in and the out, and then if she is incontinent and how much she is incontinent, okay? That's one example that we need to see. The other thing is the Squeezy app, okay? Is app through the NHS. I think it's a free app which giving pelvic floor muscle exercises, and also how to how to find the biofeedback devices. It's very helpful. Okay, you might guide your patient to go through it and have better understanding of their condition. And then coming to, and that's the ABC score. Okay, these are some of the website. Then coming to the ketamine syndrome, here how the patient, how the drug dealer, usually not the patient, because if the patient buy it liquid, most probably he will inject it. Okay, because the effect is much potent. But um, if he have it crystals or he have it, powder, they will use it as cocaine, like they will sniff it. Okay, and the drug dealer usually is the one who's cooking it and then selling it as cocaine or as powder. Okay, and these are just few more information about the ketamine and why the ketamine is used as drug of abuse. Cheap, people think it's safe, is not addictive, because medicine why we are using it, so they think it's safe, but it's not. And then it's causing dissociation. Dissociation means that the patient will not be able to uh, control his body, and he will think that his soul came out of his body, and he will be flying around his body. If you ask anyone around who's taking ketamine, he will describe it like that. He said, "Oh, my soul came out of my body, and I was looking around and was enjoying around my body." It's strange feeling, if you ask them to explain, but they find it helpful to relax them, and they find it um, relaxing. So most probably, if you treat their depression and anxiety and stress, you will be able to remove them from the medication, more or less. And we can see there is variant side effects of the ketamine, okay, and also legitimate use, but one of the most, debilitating side effects is the urinary system, okay, until they cause complete damage to the bladder, and you need just to remove it. So you could need to consider, um, the differential of ketamine abuse in any patient, young patient, especially coming with frequency urgent hematuria or urgent incontinence. Okay. And these are some learning points regarding the case, okay, that any male or female patient coming with cystitis unexplained and with culture negative, okay, and still have symptoms, you need to think of the drug of abuse. Okay, please be aware about our YouTube channel and WhatsApp group, okay? And if you need any other help and support, I'm more than happy to help and support you. Be aware that I'm giving one-to-one teaching and also giving mini mocks. I finished my teaching today. I'm very happy and open for question, either regarding this case or any other case you would like, to discuss. I will just stop the recording.